not going to be able to do something with the program I have at home. But it'll probably be closer this weekend. But that, yeah, no, that won't be on the exam. So it'll be Friday at the earliest where I can actually look at that. Let's see. Any other questions? Okay, I think it is recording, so we're good. Okay, I was just talking to Ms. Powers here, and I only have one day to cover this content, and that is just not sufficient. So she and I will talk a little bit later about what we're going to do about that. Ooh, I got to turn the whole thing off. Oh, it's not fluorescent. Throw me off. Okay. I've cut some stuff down in the first chapter, and I'll tell you, well, I'm covering it. I'm just covering it in a little different way. So what we're going to talk about first is the adaptive immune system, and then after we'll let you know what we decide. The adaptive immune system is extremely important. It's how we fight off all the things that come into our body that are not supposed to be there. Give you a definition of an antigen. An antigen is a foreign substance. It's something that's not supposed to be inside of our body. So we're going to be talking a lot about antigens today. So we're going to talk about the adaptive immune system, and then we're going to talk about some diseases that can occur when the adaptive immune system is not working like it's supposed to. We've already gone over the cells that are in the adaptive immune system. We actually talked about them in inflammation. So we've already talked about the monocytes, the macrophages, the granulocytes. The dendritic cells, they're actually phagocytic as well. And they're also, what we're going to learn in just a little bit is called an antigen-presenting cell. And so are the macrophages as well. We'll talk about those, but just make you a little note there, so we'll pull it all together in a little bit. Your lymphoid cells, and this just tells you where they come from. Your antigen-specific lymphocytes, we're going to be looking at different types of antibodies that are specific for different things. So we'll talk about those. And then we're going to talk just a little bit about natural killer cells. So just to remind you of where lymphocytes come from, lymphocytes actually start off in the bone marrow. They're stimulated in the bone marrow before you're born, actually. And then what's going to happen is you've got two types of cells that we're going to talk about initially in the first part of this, B cells and T cells. B cells actually mature in the bone marrow. They mature in the bone marrow, and then they're released, and they travel to the lymph system where they wait until they're needed. The T cells actually leave the bone marrow as immature cells, and they travel to the thymus. Now, we talked about the thymus in our very first lecture. They travel to the thymus, and they go to the thymus, and there they mature. And once they mature, then they go settle in the lymph system and wait until there's an exposure that takes place. And so the thymus is very active, particularly right after birth, when all these are moving out to mature and then going out to the lymph system, and then the thymus will regress and atrophy a little bit because it's not needed. But if something were to happen, then it will come back and start to help again if we need more T cells. You have millions and millions of these when you're born. Some of them are specific, and we'll talk about how that happens in just a little bit. Some of them become specific a little later on. All right, so one of the things I want to mention to you right now is what I just talked about is a phase in your textbook called clonal selection. Clonal selection is where they mature into T and B cells. And then they go to the lymph system and they wait until they're needed next time. And so this is a little bit different than how I'm going to cover this because, like I said, there's way too much content for the time they've given me. So I've drawn a little picture over here to try to put things together to cut down on some of the spots a little bit. I'll make notes as we go through and let you know what I'm talking about. All right, where's the lymph system? When I talk about the lymph system, what am I talking about? We have the central lymphoid tissue, which consists of the bone marrow and the thymus. I've just told you the roles of the bone marrow and the thymus and how important they are. The bone marrow producing both B and T cells, the thymus in helping the T cells mature. And then the peripheral lymphoid system is where they go and wait. If you were to cut open a lymph node and look at it, you would actually see sections in there, some for the T cells and some for the B cells. So it has little compartments in there where they go and wait. And what happens is in the lymph system, there's fluid that drains through there. The lymph system is developed where blood vessels come together. And so there's fluid that drains from those. And so any foreign substance or byproduct of any, we talked about all these byproducts and stuff that's broken down into cells or killed, comes through there, it's going to go through the lymph node and it's going to be sensed. And what's going to happen is either B and T cells are going to respond at that point. So the lymph system is very important and lets stuff to drain through and sort of filters through, and it's constantly looking at it and seeing if there's anything foreign in there so that it needs to respond. And then the spleen is important, in that the spleen really cleans things up. As the blood goes, the spleen is very vascular. It stores a lot of blood itself, but it also a lot of blood goes through there. And what happens is it filters out. If you were again to cut the spleen, open it up, you would see what we call white pulp and red pulp. The white pulp is where it filters out all the old white blood cells, any damaged white blood cells, any byproducts of any infections that you've got. And then you have the red pulp, which actually filters out the damaged or old red blood cells. So the spleen is very important in doing that. All right, adaptive immunity. Now, we talked about 3 types of immunity. We've talked about the innate system, we've talked about the inflammatory system, and now we've moved on to the adaptive system. And they can either work independently or can work together depending on the situation, what's going on. But the purpose of the adaptive immune system is to destroy any infectious organisms. Hopefully inflammation will take care of it, but if not, then here comes the adaptive immune system to the rescue. It provides long-term, highly effective protection against future exposure to the same organism, meaning the first time I'm exposed to it, we're going to develop some antibodies, and those antibodies are going to develop a memory. So that next time when I get exposed, I'm going to have more resistance to it, and I'm going to have more antibodies to respond more quickly. So it allows you to respond more quickly and more effectively the second time around that you're exposed to something. So that's what that means. Inducible means that it comes in contact with something foreign, it's not supposed to be there, and it can be induced. It recognizes that it's needed. It is specific. We're going to talk about antibodies that are specific for certain things. And then in the end of this whole system over here on the board, in the end, what's going to happen is, I think I'll write this down here. I think right down my pen. We're going to have antibodies and T lymphocytes. Immunoglobulins are also known as antibodies. We'll do this in a minute. But I forgot to drop it on there. That's important to know. All right, in your textbook, it makes a big deal of talking about humoral and cellular. I think it could be organized a little bit differently because I think it's a little bit hard to understand. But it just tells you humoral and cellular divides into different components. Humoral is actually the immunoglobulins or the antibodies that are floating around in the bloodstream a lot of times. Sometimes they can be in some tissues, but most of the time they're floating around. And so the humoral is simply the antibodies that have been produced. You've had an exposure. The exposure resulted in antibodies being produced. These antibodies bind to antigens. Antigen, again, is a foreign substance. It's not supposed to be there. So these antibodies will bind to that and hopefully stimulate destruction. The cellular component of the adaptive immune system is your T cells. And we're going to talk about the subpopulation. There's something called effector T cells, and so the T cells I'm talking about cause some effect directly. They can actually cause direct effects. And so we're going to be talking about the cytotoxic T cells. There's also a natural killer cell, and then we'll talk about the T regulatory cells, a little different component. Both of these components, humoral and cellular, both of these can develop memory. Now, are they separate? No, they can work together. So, and actually, I've written it over here. As you can see, it's all coming together. I don't know if it's part of the back. Maybe come up here and just use it. You can see it that way. I need a giant board for this, but they do work together. And at one point, we'll talk about how they can actually, one part's needed than the other one. It communicates so that the humoral section can actually work better. So the cellular section helps the humoral work better. Okay, a couple of definitions for you of why we care about this is we really are concerned about immunity and what kind of immunity that you have so that you can fight off what you're exposed to. So active immunity means that you are actually exposed to an antigen. Somehow the antigen has gotten into your body and your body's doing all the work at this point. I think that's one of the easiest way to remember. Your body's doing all the work when you look at the difference between active and passive. Antibodies or T cells are produced, so antibodies are B cells. You write B cells every time you see antibodies or immunoglobulins and B cells, they're the same thing. Produced after either natural exposure, meaning somebody coughed in my face and I breathed in and I got the flu that way, or cold or whatever it is. Right on there. All right, very good. Or after immunization. Immunizations are when you're exposed to an antigen, but the antigen has oh my goodness, the term has gone out of my head. Attenuated. It's either an attenuated live virus, attenuated, A-T-T-E-N-U-A-T-E-D, attenuated, which means it's weakened. They have gone in there in the lab and they have weakened that virus, so it's not supposed to cause terrible disease in you, or it's a dead virus. Those are the two things that we'll use. We go in the lab and we mess with them and make them attenuated, or we make a dead virus vaccination. So that's what immunization is. So what we do is we expose you to that. It's in small quantities. It's either weakened or dead, so the body can recognize that it's foreign and start building up antibodies, but you should not get sick from it unless your immune system is not working like it's supposed to. All right, so questions about active. So you're actually being exposed to that organism. Passive immunity means that you're getting some help from somebody else's antibodies. All right, you're not doing the work. Your immune system is not doing the work. We're giving you some antibodies, and that can happen two ways. It can either it can be from the mother to the fetus. That's passive immunity, as the blood is transferring back and forth. That's passive immunity. We also have the ability to give some preformed antibodies, meaning that we've taken them from a donor and we've made something that we can inject into you. The best example of that would be hepatitis C. Well, when I say that, wait a minute, not the actual hepatitis C virus. But if you as a nurse are exposed to, or anybody else is exposed to hepatitis C, and we know you've got a needle stick, we know the patient has hepatitis C, we can actually give you preformed antibodies to boost your immune system and hopefully prevent you from developing hepatitis C. We have a window of opportunity there. We have to get it in with a certain amount of time, but and there's to learn all about that as you're going through here. So there's two things we look at: preformed antibodies that we can give to you, and that would be if you've had an exposure to prevent you from developing the disease, or from the mother to the fetus. These two examples of a passive, where the antibodies are already present and we're simply giving you those antibodies in one way or another. Questions about that? Okay, I've already given you a definition of antigens. An antigen is anything that's foreign, binds with the antibodies, which and there's receptors on, we'll talk about T's and B cells that can bind to. And it's not necessarily immunogenic, and I'll give you a definition of immunogenic, that's important. The difference between antigens, not all foreign substances, if that were the case, if they induced your immune system, we would be having immune reactions all the time. So it's not necessarily immunogenic, meaning that it can induce the immune system. That's what an immunogen. Immunogen is able to cause the immune system to respond. It produces antibodies or T cells. Now, what's the difference? Well, it depends on how foreign it is. The body, we have things in our body that are considered our own self-antigens, but they don't cause them, in normal individuals, they don't cause an immune response. We have a system set up in our body. We have what's called a T regulatory cell. It's a T cell, but it's called a T regulatory cell. It prevents our immune system from recognizing our self-antigens as foreign. So we have foreign antigens in there. So one of the criteria it's able to be able to do something is how foreign is it? Is it very similar to our own, or is it really, something that the immune system goes, ooh, I've never seen this before, this is not supposed to be here. How big is it? What is the quantity of it? It needs to be a sufficient quantity in order to catch the attention of the immune system. So if it's one, then what's going to happen is inflammation is going to take care of it. The innate system may take care of it. It may never even get into the body. All of these are foreign, but some of them are not sufficient enough to cause an immune response. They're not immunogenic. How can these get into the body? Oh, anyway, we can breathe them in. We can take them in by mouth. We can inject them by IV. They can get on your skin, be absorbed that way. Anyway, we get them in a whole host of ways. There are some genetic factors that we have to look at in terms of how our immune system is working. In fact, there are some individuals that are predisposed to having more allergic reactions, more immune responses. Other factors that can affect your immune system: nutrition. If you have somebody that is malnourished, if you have somebody that has a disease such as cancer, they're also going to be malnourished too. So they have both of those things going against them. It's going to be devastating to the immune system. They're going to have more of a difficult time fighting off when they're exposed to things. They get they're exposed to the flu. It could be fatal for them because they cannot fight it off. And there are certain drugs. The best example would be chemotherapy agents. Chemotherapy agents suppress the immune system. Actually, they eradicate the immune system. They kill everything off in there, or not all, everything, but they pretty much suppress it. And also, steroids would be an example. They will suppress the immune system as well. Well, that prevents the immune system from responding and may allow you to get infected with something that you normally wouldn't have gotten infected with. All right, this just tells you the components of an antigen. When you look at antigens, you have what's called an antigenic determinant. Antigenic determinant. This is actually on the antigen. It's on the antigen. It's called an epitope. And then you have a paratope, which is on the antibody. And that's really basically what that is how they communicate. The epitope and paratope are how they communicate. You have to, the antibodies have to be able to get a hold of whatever that fragment is and identify it as foreign for this process to take place. And so basically that's how they communicate. I've already given you a definition of self-antigens. I skipped ahead a little bit. Self-antigens are what we have in our body. The T regulatory cell is extremely important in being able to manage this and prevent our body from attacking itself. So the T regulatory cell, don't worry about the central and peripheral columns, don't worry about that. Tolerance simply means that we don't attack ourselves. The body is prevented from attacking, it prevents the immune system from attacking itself. It's called self-tolerance. So we don't attack our own antigens. Now, can there be situations that occur when we do attack our own antigens? Yes, autoimmune diseases. We're going to talk about this later on. So when we lose self-tolerance, we develop autoimmune diseases. All right, so tolerance means that we don't attack. If we lose self-tolerance, that means we do, and we have autoimmune diseases that develop. We're going to talk about this in a little bit. I want to mention one thing. It's called, in terms of being able to stimulate the immune system, one of the things you have to look at is how big is that, the size of whatever it is, the foreign coming into the body. If it is small, too small to really catch the attention of the immune system, it is called a hapten. The problem with haptens is they can actually, and poison ivy is the best example for this. This is in your textbook. Poison ivy. Poison ivy by itself, it is too small. It's actually the oil. I'll say poison ivy. It's the oil off the poison ivy that does it. That molecule in that oil is too small to cause an immune response. The immune system doesn't pay attention to it. But when it gets on your skin, it will bind with your proteins. And when it binds with the proteins in your skin, it becomes larger. And then the immune system responds. And you have an allergic reaction to poison ivy. And that's not everybody. I can't say why. Some people, it just doesn't bind. It never happens. Their immune system doesn't care, which I'm very jealous of. Allergens are things that cause allergic reactions. We're going to call that's your hay fever, dust mites, any of those things. We'll talk a little bit more about those later on. Questions about that? Questions about antigens, foreign substances, self-antigen intolerance. All right, and this is just, we've already talked about it, the innate immune system. This just shows you the components of completely gone out there. Adaptive immune system, the B cells that we're talking about, and we'll talk a little bit more about plasma cells in a minute, and these are the T cells, and we'll give you some more specifics in just a second. Okay, so I mentioned that humoral immunity was actually your B cells primarily in the blood. They are produced by plasma cells. Plasma cells are floating around. Those are the ones that are in the blood. When they become exposed or actually told to by another part of the immune system, they will develop antibodies. Again, there's a communication structure that has to go through. We'll go over it in just a minute. I'm going to give you an overview of the different types of immunoglobulins, or also antibodies, and tell you what they do before we continue. All right, so I've already mentioned the antibodies are also called immunoglobulins. They're produced by the plasma cells, and basically what antibodies are, they're simply protein fragments that are given out by those plasma cells. Once it identifies that, it either has a memory or it's gone through this process that we're going to talk about, what's going to happen is it's going to produce these antibodies in response to whatever foreign substance it is. And so there are different types. It tells you there how they're characterized for testing purposes. That's not really going to be important to us. There's several different types, and let me just give you an overview of what each does. This shows you the structure of the antibodies. I have no idea why that's in there. I would have taken that out. The only thing that's really interesting is IgM. IgM is really interesting because it's a pentamer, which means it has all these places on here that it can hook up with the antigens, so it can really get a lot of them in there. That's really the only thing interesting in that slide, and that's just probably me. It's the only one that thinks that's really interesting. And so let me just go ahead and do this. I've already mentioned what epitopes and paratopes are, so I'm going to pull this out and just go on. Like I said, I'm going to try to cut this down a little bit. How do antibodies work? Antibodies can work either directly or indirectly. Remember, antibodies are released in response to, they're supposed to be taking care of whatever organism, foreign substance it is. They can do this directly or indirectly. Directly, they can do it by 3 ways. Neutralization, which means they activate or bind to receptors on that foreign substance. So if you bind to receptor sites, you block those receptor sites so that it can't work. All right, so neutralization. Agglutination basically is this chemical reaction that occurs where it causes it to clump up. So instead of them not being free-flowing, they clump together. Or precipitation, which means that it becomes insoluble, which is really going to affect how it moves. Because remember, we've got to be able to move back and forth across the membrane. So it's going to really affect that. Indirectly, we've already talked about the complement system, and this is really the complement system and inflammation do it indirectly. We've talked about both of those. And phagocytosis will occur when those phagocytes are stimulated to come to the site. Just to mention, how do we know that we have protection against certain organisms? The best example, let's look at hepatitis B. Hepatitis B, you've already received your hepatitis B series vaccine. What we're doing is we're injecting you with a small amount of a dead hepatitis B. I can't remember if I said B or C. It is B, not C. We don't have anything yet for C. But anyway, we inject you with a small amount of a dead hepatitis B that allows your immune system to recognize it and develop antibodies against it. You get series of 3, which is a booster for your immune system, really lets it get nicely exposed, so you should have a high degree of antibodies in your blood. We assess this by drawing blood and looking at how many antibodies are floating around in your blood. And so what we do is we do what's called an antibody titer. That's how we assess how well your immune system is working against whatever organism. Okay, questions? And this is in your textbook, so you can take a look at that. And this is all right, this is what I want to cover next. All right, in terms of antibodies, immunoglobulin A, I want to give you a definition. There are 2 types of those, but basically these prevent the invasion of an antigen or an immunogen, depending.
Could you repeat that, please?
All right, it prevents invasion of, let's say, an antigen, and then look at the difference between antigen and immunogen, through the GI, the pulmonary system, the GU tracts. Basically, it's in secretions there, is what it is. The plasma cells will secrete antibodies in those locations and prevent you being seriously infected with. So it's in the GI, the pulmonary, the genitourinary system, and those tracts there, and it is secreted. Some examples: saliva, colostrum, which is that's what's first produced when in the breast milk. First, the mother is going to have colostrum produced. It's really high in antibodies. In the bronchial secretions, I've already mentioned, and we also have some in the vaginal secretions. I didn't mention those, but they would be the vaginal secretions as well. So it basically will hopefully protect you from localized infection, because those are all areas where you're exposed to things, and if it gets past that system right there, that layer, then you're going to have a bigger infection. So it's supposed to try to protect you from that. All right, immunoglobulin D. Now these are lower in the blood, concentration in the blood. If you were to measure those, then so I measure those normally, which is the concentration being low. They are going to be found on the surface of developing lymphocytes, and they function as a receptor site for one of those B cells. So they're actually involved in the functioning of the B cell. IgE we're going to talk about a lot. IgE, while it is the least concentrated of the immunoglobulins in the circulation, or actually in the bloodstream, it is extremely important in allergic reactions. In fact, when we find IgE actually on mast cells as well, so it's not just circulating in the blood. They're low concentration in the blood, but the majority of them are found on the mast cells, which of course are lining everything that we talked about earlier. And so when you're exposed to anything that causes an allergic reaction, the mast cells are going to degranulate, and that's going to cause all those things we talked about in the inflammatory process. We also find them to a lesser degree on basophils. When we talk about basophils, we think are very similar to mast cells, but we don't know a lot about them at this point. Basophils are always circulating in the blood. All right, it does provide great protection against parasites. Again, we could look and if we've got somebody that's infected with parasites, we should see a rise in their IgE levels. So we could look at that. All right, and is that a duplicate slide? It is, isn't it? Yes. All right, that's duplicate of what I didn't realize that was in there. This shows you the IgE function, and I've talked about the degranulation of the mast cell because it's going to be right here is the IgE sitting on the mast cell. And so here is the antigenic fragment that's attaching to it, and that's going to stimulate the mast cell to degranulate, and it's going to release histamine and produce all those other factors that we talked about. All right, IgG, they take up the most space in terms of being 80 to 85% of those that you see. What they're going to be accounts for most of the protective activity against infections. One of the big things with this one is it actually is transported across the placenta. And this is one of the things that we see in passive immunity, where the mother transfers those antibodies to the baby. Don't worry about the 4 classes underneath. We don't need to know that. And IgM, it is the largest, and I pointed out on that slide that it is a pentamer, which means that it has all these, don't worry about stabilized shade change, but it has all these places that it can hook up to these antigens. So it is usually the first antibody produced in response to an antigen being present. A lot of it's going to be synthesized during early fetal life. In fact, you will see if you have an infection that takes place in utero, while the baby's being developed, you'll see these elevated, and you'll know that baby was exposed during its development to some sort of organism. Okay, questions about that? Now, the secretory immune system, this is actually, we've already talked about this a little bit when we talked about the innate resistance. We talked about how that there were some things that were going to be secreted, and what I wanted to take you back to that and point out, I mentioned that there were some chemicals, some things in there that help with the immune system, and those are antibodies. So they are present in the tear, sweat, saliva, mucus, and breast milk. So here we see the antibodies, and they play a role in that innate response. All right, and this just shows you everywhere that you would see the immune system tissues, where they come in contact with. I mentioned those. Okay, so humoral immunity is the B cells. And so we need to talk about cellular immunity, which is the T cells. Now, I mentioned earlier, I know it's hard to see, but I mentioned, here are your lymphocytes. Your lymphocytes are made of the bone marrow, and then 2 things are going to happen. The T lymphocytes are going to go out to the thymus, where they're going to be matured there. The B cells are actually going to mature it, and they're both going to end up in the lymph system. That's where they're going to go to. And so at that point, what we have to look at is what happens to those cells when we get exposed to something. And so I'm going over that, and this is where it gets a little complicated. There's a section that I really want to point out to you in this process that's really, really very important in age development. So let's look at the T lymphocytes. We're going to be looking at cytotoxic T cells, T helper cells, and memory cells. Both the T and the B both can produce memory. Point that out. But for the T lymphocytes, we're going to be looking at the cytotoxic T cells, which are good for viruses and some cancers. And then the T helper cells are the great communicators. Without them functioning, nothing else in the system is going to work because they actually really direct traffic. Okay, this is what I've got here. I want these cells to develop. Okay, I've got this here. I want these cells to develop. That's what the T helper cells do. So very, very important. And then the memory cells means that next time we don't have to go through this complicated process in order for these antibodies to be produced. And I'm going to tell you what it's called, the antigen presentation process. That is a step that has to be done in order for this process to take place the first time. After that, memory develops, and then you don't have to go through that process. And so your immune system responds much more quickly and much more effectively the second time around. And so I'll show you that process in just a minute. And then one thing on here, T lymphocytes, we need to add in here, just put in there, T regulatory sites, T regulatory cells really are their own little entity because their job is to protect your own body from its own immune system. So you can add that there if you'd like. Okay, now, In your textbook, again, it talks about clonal diversity and clonal selection. And so we'll talk about just briefly, and I'm trying to write those up here again. I'll leave this up after class so you can come up if you want to write this down. But the clonal selection basically is the part where the lymphocytes mature and they go to store themselves in the lymph system. They're ready to work at that point. You have millions of these at birth, but that really is, in a nutshell, is what clonal diversity is. I'm sorry, I think I wrote it down backwards. Yes, I think it is, actually. Maybe it's off for a second. I'll fix that here. All right. All right. So what we have the clonal diversity is the production of T and B lymphocytes. That's when they are overall being produced in the body. And then clonal selection is the actual specific process that takes place so that it tells the body, do I need specific cells related to the T cells, the T lymphocytes, or do I need B cells or antibodies to do? So that's what the antigen presentation process is. It actually facilitates the production of specific cells to whatever I've been exposed to. And I'll show you that process. I've already mentioned clonal diversity takes place in either the lymph tissue, the bone marrow, and then they are mature and ready to respond if needed. And so that's what clonal diversity is in a nutshell. Now I've already mentioned, you can read through that slide. T cell development, I've already told you, it matures in the thymus, and then they're ready at that point. Now here's the most complicated part of this whole process. It's called the antigen processing and presentation. Just because an antigen is in your body doesn't mean your body's going to be able to recognize and the cells respond. It has to go through this complex process the first time that it's exposed to something. The second time it's exposed to something, it doesn't have to go through this process because it's already developed a memory of it. So the first time it's exposed to something, it has to go through this complex process, and that means that your body is not going to respond as quickly. So if I have never been exposed to the flu, the first time that my body comes in contact with that, it's going to take me a little bit longer to respond. There's actually hours and days lag time before your body builds up sufficient immunity to that. So I may get pretty sick that first time. The second time I get exposed to it, my body's going to say, oh, I recognize this, and then all this stuff's going to be produced, and it's going to be able to fight it off more quickly. So you do have to go through this first time where you develop a memory of it, and you can respond at the same time. It's going to be doing two things. When it's going through this presentation process, it will respond. It's going to be a weak response that first time, and it's also going to develop memory. So there's going to be two things that are going to be happening here. So initiated when the T and B cells interact with the antigen, but it has to be, the antigen first has to be processed. To be processed, that means it's going to be broken down by something that's phagocytic, and a piece of that is going to be placed on the outside of that phagocytic cell. A piece of that, what's left over after it's been broken down by phagocytosis, is going to be placed on the outside of that phagocyte. That phagocyte has now become an antigen presentation cell. It is going to take, it's like going to the king. This person is going to take this bounty that it has, and it's going to present it to the T helper cells. And it has to do this in the correct manner. If it doesn't, the T helper cells will ignore it. So it has to be done correctly. So it's really quite picky about how things happen that first time. All right, so you have an antigen presentation processing that takes place in a phagocyte, and that could be your dendritic cells. We talked about the macrophages. It could be any of those cells that are going to act as an antigen presenting cell, and it's going to place it on the outside. So now it can go to the immune system and it can talk to the T helper cell, but still it's got to do it in the correct way. If it does it correct, once it presents it, then what it's going to do is it's going to tell it either to produce T or B cells. All right, and I'll show you that process if it does it correctly. So for processing and presentation to occur, the antigen must be the appropriate type. So it has to break it down, put it out on the outside specifically, make sure it's the right cell or the right receptor. I'll show you that in just a second. The lymphocytes must be prepared to recognize this presentation antigen, and the antigen must be presented appropriately. So it's really picky. And this is where we have AIDS break. This AIDS right here, and when we get to this part with the presentation process, that's where we have the AIDS virus really cause the most damage, and it destroys the immune system so you can't respond. Okay, B cell activation, I've already mentioned what happens to the B cell. I'm going to move on and show you the actual presentation process. This shows you, this is what I wanted here. Okay, in order for it to be presented correctly, you have to line a couple things up. And this is what we're looking at is major histocompatibility complexes. There's type 1 and type 2. This picture just has 2 on it. All right, so major histocompatibility complexes, which you will know, you will need to know for the exam. Okay? So you have 1 and 2. What happens in this specific cell actually has major histocompatibility complex 2 on it. Here's the little piece of the antigen that is stuck on the outside of its cell. In order for this to work, it has to find a cell that has a CD4 receptor. Okay, so class 2 has to have CD4. All right, those two hook up. The other ones don't. So if it tries to present something else, it's not going to work. So it has to be 2 to CD4. CD4 is actually just a protein that is sitting on the outside of the T helper 2 cell. There's T helper 1 and T helper 2. And I'll show you that in just a second and show you how this all comes together. All right, so class 2, CD4 on the T helper 2 cell. That's the only way that takes place. You also have a major histocompatibility complex 1 that talks to CD8 on the T helper cell. All right, I'll show you that picture in just a second. It has to be done correctly in order for this to take place. Once these hook up like this, then the T helper cell is going to do its job and say, okay, I need memory produced and I need these specific cells to respond to whatever antigen it is. Okay. All right, let me see. I've already mentioned this. This is the class 2. Let me move past these pictures and find what I wanted to show you. Okay. This is the antigen presentation that I was talking about. This is a slide I think is in your textbook. I did leave it in the PowerPoint, but I like it because it does show you the class 1s. This is what you'll need to know for a test. Class 1 present to the endogenous antigens from intercellular proteins, react with CD8 on the cytotoxic T cells. That's very important. Cytotoxic T cells. What do cytotoxic T cells do? They respond to viruses and some cancers. All right, so it has recognized that it has a fragment of a virus or a fragment of some sort of cancer and that it needs to produce cytotoxic T cells. All right, so class 1, major histocompatibility class 1 with a CD8 cytotoxic T cells. And there's several of these. We're only going to do 2. Major histocompatibility complex 2, I've already mentioned, it reacts with CD4 on the T helper cell. And when that happens, it's going to recognize that it needs to produce some antibodies in response to that. And so we'll talk a little bit more about that. But that shows you how those line up. And you will need to know those because I will ask you. And the CD4 is actually what is involved in AIDS. And that's what I wanted to show you. Because right here is where this breaks down. The AIDS virus actually destroys the CD4s. And so without the CD4s, you cannot recognize the major histocompatibility complexes and you can't respond. And so your immune system simply doesn't work. Okay, so that's the AIDS virus actually destroys those CD4s. All right, questions? That's why I wanted you to see that, because it's devastating to the immune system. Without that, it can't respond. Okay, let me try this. I decided this morning because I realized that there was no way I was going to be able to cover all this. I tried to draw this out. Let's see, let me get some blocks on here. I don't know how to turn blocks on here. Let's do this. Okay, it doesn't give you much light. Everything we talked about is really right here. In terms of the lymphocytes are being stored here. They'll be stored in your lymph system. And then what you're going to have is you're going to have exposure, and that exposure is going to stimulate this process here. When you get to the T cells, and I put right here, we talked about interleukins and the interferons. This is where they're being produced right here. And so when you're exposed to something, guess what's being produced? Interleukins and interferons, which are chemicals that cause communication. And they're part of this process that allow either the effector cells or the T helper cells to respond. Now, the T effector cells, those would be your T regulatory cells, your cytotoxic T cells, and your natural killer cells. There's also some memory that develops in here. So effector means it can affect directly. So I've been exposed to something. My T cells are needed, and so I've got an effector cell that's going to be out there actually going ahead and trying to kill whatever it is, get rid of it. It's not going to be a great response because, again, I've not been exposed to it before. It's going to take a little bit of time for my response to get really big, and so there'll be some memory. And then I just made a note here for you. Here is the major histocompatibility complex 1 plus the CD8 on your on the T regulatory cells, the cytotoxic T cells have to be present in order for that to take place. I'm going to move the T regulatory cells down because that's something for somebody else. Let's put the T regulatory cells down as their own little, because they really are. Let's put them down here by themselves. They really are. So I'm moving the T regulatory cells down here. The, major histocompatibility complex on the antigen presenting cell, I was going to talk today, plus the CD8 equals the cytotoxic T cells being stimulated, natural killer cells. Alright, over here we have the T helper cells. They also are being exposed to antigen presentation process. This is the antigen presenting cell. And then the T helper 1 and T helper 2 are going to respond depending on what they're being exposed to. It may be the cytotoxic T cell, or it may be the B cells that are going to produce antibodies. And then again, I made a note here that says the major histocompatibility complex 2 plus CD4 equals the response will either get plasma cells equal antibodies. And these are antibodies floating around in your blood. And these are memory cells. You have two cells that are produced. 1 and 2. I was clear when I wrote it the first time. Alright, so T helper 2 cells, 1 and 2, are the type of cells that's going to stimulate production of. And the B cells can also have, to some extent, can respond directly the first time, but again, it's very weak, doesn't really do a whole lot.
Which clonal cell is which? Or which clonal?
Okay, this is, I'm looking at, make sure, because I did it wrong first time, I don't want to do it wrong again. Let me get my clonal, I think I had it backwards. Maybe I didn't. Where's my clonal diversity? This is clonal diversity. Did I have it backwards? Maybe I write down so that I have this. Yeah. Did I have it backwards?
Yeah.
Okay, that's what I thought. Okay. Okay. So here's diversity, here's section, let's see. Alright, humoral is in the bloodstream, and then cellular is all this takes place in here. Alright, does that make sense? I tried to take all those pages and just draw it in a concept map. I don't know if this helps or not, because it's, I think the section in the textbook is really hard to read. So I tried to figure out ways to draw concept maps. I don't know if this helps or not. So what I've done is I've just tried to put everything in there that they had. So T lymphs and B cells, they are developed in the bone marrow. The B cells mature in the bone marrow, and then they're released and go to the lymph system where they're stored. This is called diversity. The T lymphocytes are released from the bone marrow immaturely. They go to the where do they go? Thymus. That's exactly right. Thymus, where they mature, and then they go to the lymph tissue and they wait until they become exposed to that occurs. Okay, so that's clonal diversity. Most of this takes place before you're born. There is some that takes place in the first few years. Your thymus is active up until middle teenager years or so, and then it starts to regress. Okay, and then we get to clonal selection, which is when you've been exposed to something. Alright, this occurs when you've been exposed to something and you need to respond, otherwise you're just going to sit in the lymph tissue and just wait, they don't need to be used. And so what can happen is on exposure, you go through that antigen presentation process the first time that you're exposed to something. The second time, what responds? The memory cells. You develop a memory the second time, so you don't have to go through this process. The first process is the presentation process. The first time that you're exposed to something, the presentation process, it takes longer to develop, and so your response when you get exposed to something is not going to be as strong or as effective the first time around. It's going to allow some lag time between when you're exposed to that organism and when the immune system responds. So you may get a little sicker until that immune system responds that first time. The second time, you're going to have some memory of it, so it's going to go ahead and start working. Now, it's going to produce more cells to help, but it's going to have some memory to go ahead and start attacking. All right, so this just shows you in the presence of interleukin and interferons, and remember those cause fever, and if they get too high, then interferons can actually cause death in some patients. We can have either effector cells or the T helper cells. A lot of times both of them are acting together to try to develop the immune system. But when you look at your cytotoxic T cells, that's where the antigen presentation process has to take place. You have the major histocompatibility complex 1 on the antigen presenting cell, say the APC, and then this is on the actual this is on the cytotoxic T cell. CD8 is on the cytotoxic T cell. The MHC1 is on the antigen presenting cell. These two together equals the cytotoxic T cell working. Alright, and then over here we have the T helper cells, which are T helper 1 and T helper 2. And T helper 1, it all interacts, it's so hard to draw it out. T helper cells, again, an antigen presenting cell is going to come to it, and I've got that over here, your major histocompatibility 2 and your CD4 for your T helper 2 cells. That equals B cell production, and you're going to have plasma cells develop, and you're also going to have memory cells develop. And then you have that's your immune response. Immune response is so pretty. All right, questions? I know you're hot. I know you're going, oh my gosh, why am I doing this? Because there's some diseases that affect the immune system. You need to understand what's not being produced and why. All right, and I will leave this up on the board if you want to write it down. I would like some feedback. If this is crazy and you don't like it all and it didn't help you, then let me know. It's the first time I've ever done it. I just actually was sitting in my car having thoughts about this and came up with this. So if it doesn't help, if it actually made it worse, let me know. And I would never do it again. Of course, I don't guess I'll do it again either because I'm not teaching anymore. Okay.
You're gonna miss them.
I am very much so, because I actually was like this, and would teach both of these girls. Okay, questions about that? Okay, you're still here, nobody's running screaming from the room. Oh, that was just a coincidence, sorry. All right. All right, so no questions about that. All right, so that's the response in a nutshell. So let's move on. We've got a lot to try to get through today. I want to try to get through as much as I can, reasonably as I can. All right, now, I told you that when you're exposed to something the first time, you have to go through this presentation process. And so you have what we call, when you're exposed to something, primary and secondary exposures. And so this is what's happening to the human being. The primary exposure is that initial exposure that I mentioned, and you could put if you wanted to put over by somewhere in there, we could actually add this. I'll think about it, how we could do that. We could add this to it, but primary and secondary are all part of this. Primary exposure is the first time that you're exposed to something. Remember, you're going through the presentation process at that point. It takes a little bit of time, and that's why one of the reasons I went through all this is explain why it takes a while for you to develop these antibodies in the bloodstream. If I were to try to do blood, draw blood, and try to detect antibodies, it's going to take some time the first time you're exposed to something. And so this explains why. Primary exposure is your initial exposure. There is a latent or a lag period. There's a delay in the response of your immune system as it goes through this presentation process. And we're talking about antibodies being developed. Antibodies come from the B cells. So make sure antibodies are B cells. And so if I wanted to detect antibodies in the blood, I would have for that first exposure. It's going to take me about 5 to 7 days before I actually see a level of antibodies develop in the blood. All right, your second exposure, we just explained what happens and why on the second exposure. It is more rapid. Why is that?
Because we've already been through it one time.
Already been through it one time, and you have what developed? Antibodies, memory. You have those memory cells. All right, so you have memory of this organism, antigen. I don't say organism, that's not right. It's an antigen fragment. So it's more rapid. Antibodies can be produced in greater quantity more quickly because you're already from your body, your immune system is already familiar with whatever it is you're exposed to. They don't have to go through that. This whole step right here, right where it's being presented, is gone. We take all this out and go directly to the antibody production, which is right over here, behind here. And go straight to it because it has memory. All right, I've already mentioned this. I need to look at this. I'll take this slide out as well because we already explained this. In order for this to take place in recognition and response, we've already talked about your cluster differentiations over here. This is two that you'll want to know for your exam. It's a big family of little molecules of proteins that are actually on the cells. We're only going to do those two. And this is a slide to show you again everything that I talked about: T helper cell, CD4. With your major histocompatibility 2 proteins on the receptor sites of the cells allows the immune response to start. Your cytotoxic T cells are a little differently. This, when you look at the T helper cells and CD4, this is where you have to differentiate into your B cells. You're actually over here, differentiating into plasma and memory cells. Whereas the cytotoxic T cells, once they're stimulated, they'll go ahead and kill. Now, they only respond to viruses and cancers, so they're only good for certain things. All right, T helper cells, we've already mentioned those. We have T helper 1 and 2, and you see what their roles are, so I can step through that. I don't really know why I decided to drag this out so much, but there's several, so maybe to help you learn. Don't worry about super antigens. We will not be covering those. We'll talk more about super antigens and sepsis later on in the program. So you can mark that off, mark this slide off. All right, I've already mentioned cytotoxic T cells. Natural killer cells, T regulatory cells, make sure you know what they do. What do they do? It's on the screen, so. But don't tell me that they survive peripheral tolerance. What do? That's right, exactly. They prevent the body from attacking itself, attacking its own antigens. So we have to have T regulatory cells, otherwise we're going to start attacking our own antigens, destroying our own tissues, and that's what happens in autoimmune diseases. Our immune system starts attacking and starts causing damage to that inflammatory response that we talked about. Don't worry about pediatric immunity and age immunity. You can just read through that. I'm good. And we won't do the questions because we are not doing it on time. Okay, so let me bring up the next PowerPoint, which is supposed to be right there, but for some reason it's not. So give me just a second. We are going to do I believe that takes us to chapter 7, correct? Okay. And so I have 3 separate PowerPoints. This is infection disorders. Infections. Yes. Okay, we'll do infections first. So that's the PowerPoint we're going to be doing as soon as my computer unlocks. And I can bring it up. Oh, I got a mouse. Drives me crazy. Anything? No. I'm sorry, it's locked up. Hang on a second, Will. Okay, here's what we're going to do. I'm sorry, I'm going to just try to shut down PowerPoint. Pause. I'm sorry, my mic seems really loud, but I'm trying to hopefully do it so it's recordable. Okay, so we're looking at types of infections and how we get infections now that we've learned a little bit about the immune system. And so this takes you through the learning objectives. You can read through those. And then let's go ahead and talk about specific things. We talked about in one of our first lectures, we talked about the term normal flora, that there is a relationship there where it's in homeostasis. Some of them are actually beneficial. Some of them don't do a thing for us. They just happen to be living in our body. And as long as that homeostasis is maintained, everything's okay. It is when something happens to upset homeostasis that some of these organisms can actually cause a problem. And I gave you 2 examples. One was yeast. When you have antibiotics, sometimes the antibiotics will kill off the flora in your stomach and allow yeast to overgrow. And so you can actually develop a secondary infection, which is what we call an opportunistic organism. It takes the opportunity to cause a problem. So an opportunistic organism. And the other one that I gave you an example of was Clostridium difficile. Clostridium difficile lives in our gut. Doesn't cause any problems, and it may even be a little helpful in metabolism, breaking down food. But boy, if you take antibiotics and allow this to overgrow, it is going to cause you some problems. It causes a lot of terrible diarrhea, really nasty diarrhea. It's awful. But it can be very dangerous to the very young and the very old because it can cause, all that diarrhea can cause terrible dehydration. So those are 2 examples of opportunistic organisms that can take over and cause problems. What needs to be present in order, what are characteristics that need to be present in order for infection to take place? I've got some terms there for you. The first one is communicability. Communicability is the ability to spread from one individual to another. The ability to spread from one individual to another and cause disease. That's communicability. Able to spread from one person to another and cause disease. Immunogenicity. Immunogenicity is the ability of that pathogen. And pathogen means to cause disease, disease producing. The ability of the pathogen to invade and multiply in the host. ability of the pathogen to invade and multiply in the host.
That's immunogenicity.
No, I'm sorry, immunogenicity, I'm sorry, I just was thinking all the thing. Alright, wait a minute. Immunogenicity, what do you think that means? I gave you a definition a little while ago. It is not what I just told you. It induces immune response, very good. Okay, something like that happens and you go, wait a minute, this is not right. Throw your hand up, it's okay, you know. It's been a long week already, so it's alright, throw it up and it's alright, I will appreciate your suggestion. Alright, so immunogenicity is the ability of a pathogen to induce an immune response. To induce an immune response. Some days I feel like I have ADHD and I just can't focus. Alright, infectivity. Infectivity is the ability of a pathogen to invade and multiply. Infectivity is the ability of a pathogen to invade and multiply in the host. Invade, I sound like evade, but invade, and multiply in the host. Pathogenicity is the ability of that agent to cause a disease. The ability of that agent to cause a disease. And pathogenicity is dependent upon how communicable it is, its infectivity, the ability of it to cause damage once it gets in the body, and its virulence. And I'll give you a definition of virulence. So it's the success, the pathogenicity, the success of it being able to cause a disease is dependent upon its communicability, how easily does it spread, its infectivity, the extent of the tissue damage that it can cause, and its virulence. There's also something called toxigenicity, which is its ability to produce toxins. So that would be an exotoxin if it produces it, but it also can have the ability to stimulate our body to produce certain endotoxins that are also damaging to our body. So the ability to produce non-exotoxins inside our body, or the ability to stimulate the production of our own endotoxins that are damaging to the body. And then virulence is the capacity of the pathogen to cause severe disease. Capacity of a pathogen to cause severe disease. For example, measles. The measles virus is really low virulence in terms of it's being able to cause severe disease. It's very uncomfortable. You don't like having it. But it doesn't, it's not often fatal. While that's the measles would be my example there. So it's low virulence. While rabies, on the other hand, is high virulence. If you don't get treated really quickly, we give you those shots to try to prevent you from developing rabies, it's fatal. Low virulence would be measles. Measles, you get measles, or we don't do anything for it except treat your symptoms. Try to make you as comfortable as we can. Of course, we hope you get your immunizations. We don't have to worry about it to begin with. But if you don't and you get measles, then we're going to treat your symptoms. We can't do anything for the disease. And it typically doesn't harm you. Whereas rabies, we're really trying to be very aggressive to prevent you from developing rabies. But if you do, it's fatal. Okay, so that's severe. It causes severe disease. Okay, questions about those characteristics? All right, so how does an infection take place? Well, the microorganism has got to get in somehow, and so there's several ways that it can do that, which we've mentioned some of these before when we were talking about how antigens get in. It's a route by which the pathogenic organism infects the host. One is by direct contact, so you come directly in contact with it. You inhale it, so I breathe it in. You ingest it, so you eat some contaminated food, oral fecal route. It can be the bites of the animal or insect, ticks, mosquitoes would be a great example there. It can also be what's called penetration, which means that you get IV. You're actually breaking the skin and injecting it into you. So those are how these things can get into your body. So there's a lot of different routes, and that's why it's really important that your immune system, particularly the innate first off, and then inflammation and the adaptive immune system are functioning well so that they can attack these things and get rid of them. What are the stages of infection? There is colonization, and colonization is really sort of funny because it moves into your body, and it's actually growing and multiplying happily, living there, and it's not causing any problems. You have no symptoms of disease. You have the organism is growing in you, but you have no symptoms. So when you go to the clinical, you're going to hear that I have a patient, and he has methicillin-resistant staph, that's a problem. We'll talk about all the things you need to prevent from getting that. And he's colonized with it. That means he has it, but he is not showing any signs of active disease at that point. And then something may happen that's going to allow it to start to move out. It's going to start to invade, spread, and multiply. And it may be that maybe you've gotten under a lot of stress. When you're under a lot of stress, cortisol is being released. It suppresses the immune system. And so nursing school is great for suppressing your immune system because you're under so much stress. And you tend to get a lot of colds and things like that. When I worked night shift, I never did just a night shift. I just never could sleep well during the day, and I never felt rested on night shift. I got sick all the time. I learned after a while to start taking large doses of vitamin C, and that would help boost my immune system up. But my immune system was down, and if somebody had it, I caught it because my immune system was down from the stress of working night shift. So stress can be something that's stress, or if you're sick, you've got a cold, and you get exposed to something else, it's going to allow that something else to maybe be a problem. So that's how the infection takes place. Something allows it to get in. Your body, your immune system that we talked about, is not able to fight it off and allows it to take over and cause some problems. This is just a whole host of different things that we're talking about in terms of infections, organisms. You should have been exposed to these a long time ago. I just want to mention a couple. Chlamydia and rickettsia, they actually live inside the cell to metabolize. They're very similar to viruses in that aspect. They can't live independently. Viruses, you can go back up there and just make you know, we've talked about it before, they actually become part of the DNA structure of their own cell. They cannot live independently. They have to get inside your cell and become part of the process. And then they start shedding off fragments that go infect other cells. You need to add on here arthropods. Arthropods, and those are your mosquitoes and your, that's the stuff that you catch from them. And then prions are not on there. A virion is a fragment of a virus. I need to put that a little differently. But a prion is something that's a little bit different. And I just bring this up because we actually had a case not too long ago. It is a small altered infectious protein. A small altered infectious protein. And something has happened to alter it so that it is not broken down like normal proteins. It does not break down into amino acids like they normally should. The problem with it is it collects in the neurons and actually causes degeneration of the neuron. It causes demyelinization and the neurosystem breaks down. It typically is a slow progression, but it does lead to death because there's nothing that we can do about it. It is actually a protein. We can't give you an antibiotic. We can't give you an antiviral. There's nothing at this point that we can do for it. This is mad cow disease. That's what this is, mad cow disease. It's caused by a prion. And people say, well, we don't see mad cow. We actually had a case here in the last year of a young late 20s individual who had mad cow disease. So, and like I said, it's slowly progressing, breaks down the neurological system, but there's not anything that we can do about it. Once you're infected, we have nothing at this point that we can do for that. All right, and this just talks about antigenic drift and antigenic shifts. And this explains why each year they have to undergo looking at changing our flu vaccines. And it's because that as things, they can mutate. Basically, they can mutate and they can change. So each year they have to, and it's an educated guess. We don't know what kind of flu it is. We try to look at what we're starting to see, and they'll start producing the flu vaccine based on that. But there can be one, it can drift and change a little bit. Shifts when you actually see a mutation and a new one occurs. and that would be H1N1. We had H1N1 occur, and it caught us by complete surprise because we were not projecting for that to occur, and we had a lot of people get very seriously ill, and a lot of deaths occurred because it actually hit the fluke. We had a complete mutation and a new one developed, so that can occur as well. And so that makes it really difficult. Oh, did this go dead? That makes it really difficult in terms of how. Yeah, it did. I'm sorry, I've got some batteries here. And then I'm going to hand this off to Faye, and let Faye switch it out for me while I keep talking. I'll try to be a little louder. I don't remember. I think it's a 9-volt, but I can't remember. All right, so viruses can be quite tricky. It's hard to treat them because, again, they're a part of your own cell. We can't give an antibacterial, an antibiotic, and kill it off. We can't do that because it's actually part of your own cell, so they're very hard to treat. We do have some antiviral medications, but they're basically to prevent other cells from being infected with it, so we try to limit the number of infections there. Okay, I've mentioned bacteria. Bacteria can actually live independently, whereas viruses cannot. They can live independently in your body, so we can use antibiotics for them. They actually live off the host. And like I said, we have some bacteria that does live and doesn't cause any problems. It's when they decide to overgrow and infect and multiply that they start damaging the host. So as long as homeostasis is maintained, or it's one of our, it's one of our normal organisms, we do okay. Problem with bacteria, I've already mentioned, they can either produce their own toxins, which are exotoxins. These exotoxins are damaging. They also cause the immune response to occur. And at the same time, we can have those endotoxins, particularly interleukin and the tumor necrosis factor, be produced, and those is what causes your fever. So these two, exotoxins, endotoxins, this is where you see your fever develop. Thank you. All right, so your bacteria, and they're tricky too. One of the things you'll learn next semester, I guess you're going to do pharmacology next semester, get used to new curriculum. One of the things you're going to find is bacteria can actually evade us. They actually can change the type of, we may give an antibiotic that actually deals with them producing this exotoxin. Well, they get really tricky and decide to change the exotoxin that they're producing. They can actually do that. They can change their cell wall so that the antibiotic you're using now can't get in. You're going to learn they're very, very tricky. And so that's why it's really important that when the doctor gives you your antibiotics and tells you to take it 7 to 10 days, you do. Because if you don't, and you only take it 5, that just allows the bacteria to evade the system. It'll allow it to make these changes because you didn't kill it off. So it can be very tricky and change and cause lots of damage in your body. All right, bacteremia, this is just some definitions. Bacteremia is the presence of bacteria. Septicemia means it's growing and it's causing terrible problems. Once it gets into the bloodstream, you have a problem. That is a very serious situation and it's difficult to treat. Particularly if it is gram-negative. Gram-negative causes a lot of problems. And so you have those toxins actually being released into the bloodstream. And so it can actually end up with something called septic shock that you'll learn about later on. It's very hard. Sepsis is extremely hard to treat. We recently, I guess it was last year, they thought they had actually come up with a medication that could actually treat individuals that were in this gram-negative sepsis. We were all very excited because a lot of your patients will die in sepsis. You can't get them out of it depending on the status they were in before. Turned out it hadn't pulled the market. People were actually dying more, so we were very disappointed. We thought we really had something for sepsis. But so our thing is we need to prevent sepsis from occurring is what we really need to do. All right, viruses I've already mentioned. They actually live inside the cell. They become part of the replication process, and they spread cell to cell by shedding these little virions, these little fragments of viruses, and those little fragments go and they invade other cells, and that's how they spread. The good news is that it's usually self-limiting. These cells are going to be taken out of circulation, and the virus is going to wear itself out. The one exception to that would be the AIDS virus. There's a couple. There are some exceptions. One most notably is the AIDS virus, which actually can get in your body and be dormant for years and years and years before it starts causing problems. Okay, this just takes you to the process of how a virus replicates and shed. I'm going to let you read through that because I've actually said that several times. All right, and the video is posted on the website, and the cell effects of viruses, I'll let you read that as well. We've already mentioned that. Funguses, they're your yeast, single-cell yeast. They usually don't cause a lot of problems until homeostasis is altered. They do like, things to be wet and moist. They grow best in wet, moist, warm environments. So you do see them in areas on people's body that are wet, warm, and moist. That's where you'll see them most often. Tend to be a problem if your immune system is a little bit suppressed, which can be you're on antibiotics or on some medication that's suppressing your immune system, such as steroids. And then it's going to allow that to happen. In terms of the fungus, it's really interesting to know that actually your phagocytes and your T lymphocytes are responsible for attacking those and trying to get rid of it. We have some medicine that does a great job too. And I'll let you read through this. We're not going to cover this this time. Parasitic infections, we've already mentioned those worms. You will not be tested on those, so you can just read through this. This is really just a review. In terms of how does an infectious disease clinically manifest, we talked about local versus systemic symptoms already. It does depend on the pathogen and how much trouble, how much damage can it cause, how much interleukin and human necrosis factor is going to be released, how many exotoxins that it's producing. And so the first thing that we're going to see is fever. Fever is generally beneficial up to about 101.5 is when the doctor will cut off. You'll have a patient and the order will say, don't give Tylenol for temperature greater than 101.5. We don't treat it if the temperature is less than 101.5 because it is beneficial. That elevated temperature, usually those organisms don't like the elevated temperature, and so it slows down the replication process, allows our medications that we're giving to help. And there's some other things that you'll learn about a little later on that it helps with as well when you do fever. This you've seen before, infection, inflammatory response is going to cause some specific signs that are going to be your local ones, actually at the site, which is great. It sort of pinpoints what we're dealing with. The non-specific symptoms, that is your fever and your, what's the other non-specific symptom that I told you about? We did inflammation. Fever and, what are you going to see in your bloodstream? What will you see elevate? White blood cells. You're going to see leukocytosis, so your white blood cells are going to elevate. That's non-specific. It just tells me there's a problem. It doesn't tell me where it is. So those are your non-specific signs. All right, so what are some things that we can do against infectious diseases? Well, we have vaccines. I talked a little bit already about how vaccines work. We hope that they will produce an immune response and develop antibodies to protect you so that you're ever exposed to it, then you won't develop that disease. These are just the different ways that we develop these. We can give you an attenuated organism. Attenuated means a weakened live virus. All right, so it's going to allow the immune system to recognize it, but not cause the disease in you is what it's supposed to do. The only exception to that is if you do have somebody that has a suppressed immune system, you do not want to give them a live virus because their immune system is going to not respond and they're going to get sick. So that would be the only exception to that. It could be a killed organism. It could be something that we developed in the lab. There's several things that you do. So that's just for your information. You do know what attenuated live virus is. I've said that I don't know how many times, so that ought to clue you in. What are antimicrobials? We can have antimicrobials. They address a microbe. They're against a microbe. They can be bactericidal, which means they kill it. Bactericidal means they kill it. Bacteriostatic means they beat it back. They actually just beat it back. They don't get rid of it, but they beat it back enough to allow the medication to work. And this just shows you how they may do that. This is something you're going to cover when you do your pharmacology. You'll talk a little bit about that. So for time purposes, we won't go over that. Resistance can occur. I've mentioned this a little bit with taking your antibiotics. If you don't take them like you're supposed to, we can have resistance that occur. We have a lot of problems with resistance. We have several organisms that now have resistant forms of that we don't really, in some cases, don't have really some awful drugs to treat them with. And so how does that occur? Well, they can mutate. They can actually change their receptors so that the antibiotic that was going inside the cell and destroying it now can't get in. And this can happen by you not taking all your antibiotics. You take just enough for that bacteria to recognize the antibiotic is there and make these changes. So the next time they can say, okay, let's give you another round of those antibiotics because the first one really did a good job. Guess what? It's not going to work because the bacteria has changed to evade it. And so that's how resistance develops, because people do not take their medication for the full time and kill off that organism and get rid of it, allow the body to take over and take care of it. They take it just enough that the organism can say, oh, I recognize penicillin, so now I'm going to become resistant to it. I'm going to change my structure and my receptor site so that it doesn't work. It can actually produce some exotoxins that will destroy the antibiotic. So there's several things that it can do. And then I've already mentioned how normal flora can be destroyed. Clostridium difficile is the most virulent one of the bunch. It really can cause some major problems. Vaccines, we talked about those. You can read through this slide because the CDC does work with that. We actually have a schedule for vaccines. It's vaccines for everybody. It's not just for pediatrics. There's certain things that we should do. Every 10 years we have to get tetanus. Very good, thank you. The 10 years everybody has to do that. As you get older, there are some vaccines that are recommended for older adults as well, depending on their disease state. So there is a schedule of when vaccines should be done. Development is very, very expensive. It costs millions and millions of dollars, and so there is some, there is some concern about why we don't see more vaccines for things. And it's because it's so expensive, and they're not going to do it if there's not really a payout for them. It's just sad but true. All right, there are certain things that can develop when your immune system does not work like it's supposed to. So that's all we're going to talk about, infections. So that concludes that section of infections and how infections can develop. What we're going to do is talk about disorders that can occur in your immune system, and so we'll start with immune deficiencies, which means the immune system is not working well, it is deficient. And it says failure of immune mechanisms of self-defense. Basically, it cannot protect the body from whatever is invading it. It can be primary or secondary. We're going to talk about secondary, the acquired types. We're not going to worry about the primary. It's pretty rare. And so things that you can see in terms of presentation of immune deficiency: hallmark sign, unusual or recurrent infections. They keep coming in. I can't get rid of them. They have some strange infections. Honestly, my sister right now is having, as we speak, is having a bone marrow biopsy. And this is why. There's something going on with her immune system because she keeps having issues, not serious issues down there, and I know that's a type of thing she won't care to explain it to you. She keeps getting infections, and we can't get rid of them. We give antibiotics, and another one crops up. We get antibiotics, so it's something with the immune system. And I suspect there probably is some sort of immune deficiency going on that's causing her not to respond. So she keeps getting those. That is a hallmark sign of having an immune deficiency. If they keep getting repeating infections, a lot of times they're unusual infections that you don't usually see, that usually the body will fight off, and this time they can't. It usually represents either a T cell or a B cell deficiency, and so if it's a T cell deficiency, well, what do the T cells do? They fight off the viruses and the yeast and some fungus and things like that. So if it's a T cell deficiency, you're going to be more likely to see unusual viral infections, fungal infections that just won't go away, yeast infections. We're talking about jock itch, vaginal yeast infections, whatever it is. And it may even see some atypical organisms develop. B cells, now B cells are going to develop into antibodies, and they're going to stimulate the ability of the complement system is going to get involved, and oxygenation is going to occur. So if you have B cell and phagocyte deficiencies, well, that's going to impact the ability to destroy those organisms. So that's going to be quite significant in the ability of the body. They're not going to be able to fight off. And so you also have specific complement deficiencies as well. There are 5 groups. You write down here, we are not going to learn the 5 groups. It's just really not going to be important for us to know in the primary immune deficiencies. Like I said, these are rare. You don't see these as often. The secondary ones, and I'll let you watch the video later. The secondary ones, we see these more often. They're more common than the primary, so it's going to be the ones that I focus on the most. What are some causes of secondary deficiencies? Can be stress. It can be that you're sick from you've had a really bad cold, and you get exposed to something else, and your immune system just happens to be down when you get exposed, so it allows you to get that illness. Developing a yeast infection secondary to being sick would be an example. So it could just be normal stress or being sick of one thing and getting exposed to something else. It could be dietary insufficiencies. Your B12 folic acid is extremely important in the development in your bone marrow, developing those immune cells. So you need those to be able to fight it off. You need protein and everything, but the dietary insufficiencies. Cancers can, especially if it's one in the blood, can actually just devastate the ability of the body to respond to any pathogen. So they get lots of different things that they're exposed to. You have to be very careful. Physical trauma, when you have physical trauma, we're talking about you had a car accident, or you got major burn going on, whatever it is, something really big that is your body's been working really hard on, it's depleted the normal resources, and there's simply not enough to fight something else that's going on. Medical treatments, chemotherapy is the best example. It suppresses the immune system, depletes the immune system. A big infection going on, and then acquired immunodeficiency syndrome, or AIDS. So those things can actually cause a secondary deficiency, and we'll talk about AIDS a little bit more. All right. Any questions about that? All right, so let me just mention AIDS. That's going to be, for the test, you're going to look at secondary deficiencies, what causes them. I just went over that briefly. And just know that T and B cells and some complements, that's going to be it. Your acquired immunodeficiency syndrome is the other thing that we're going to cover. Because we actually have been doing really well with this. We had saw the numbers were actually decreasing, and now they are increasing, especially in young adult women, teenager and young adult women. We're seeing an increase in numbers of HIV. And so it is caused by a virus. It's caused by the human immunodeficiency virus. And the problem with this is that it actually destroys those T helper cells. When the T helper cells are destroyed, we've lost our CD4s that are on those T helper cells that would have allowed us to identify things that are coming in that are being presented, and our immune system doesn't respond. Basically, our immune system doesn't really recognize those things that the T helper cell would normally be involved in. This just gives you a number of the cases that we're seeing, but like I said, it's on a rise. It's on the rise. It's on the rise in women, young women is what we're seeing it and rising in. All right, there's been a lot of work that's been done with the AIDS virus. When it first came out, I remember when it first started, there's nothing we could do. Basically, it was death sentence when you were diagnosed with this, because yet we had absolutely no idea what was going on, how to treat it, what to do, and the patients and people that I knew personally that were exposed to it, they died. We weren't able to do anything for them. We have made huge strides. The best example I can give you is Magic Johnson. He is a fantastic example, because I can't remember, I need to go back and look for sure, but how long has it been since he came out and said he'd been exposed and he'd been diagnosed? It's been 20 years? 20 years? And he's been asymptomatic. He's doing fabulously well. Now, of course, he has lots of money and he can afford lots of that medication. It's very, very expensive. But that just shows you how well those medications can work. It just blows me away, because like I said, I had patients and people that I knew, they got it and they died, and I knew one that he was diagnosed, and a year later he was dead. There was nothing we could do for that. So Magic Johnson being alive and well 20 years is absolutely amazing to me. It is a bloodborne pathogen. We can get it several ways. Sex is the most common route. We can also get it through breast milk. So it can be transferred to the baby. It also can be transferred in utero to the baby. It can be, now I'll say this, but let me be very clear about this. It can be gotten by transfusions, but they have made a lot of strides. That was the other thing that we saw when this first came out. We had no idea how to detect it, and so we had contaminated blood, and transfusions were given, and people they contracted AIDS that way. Now we know to look for it. As far as I know, I really haven't heard of any cases. I want to say it's eradicated that way in terms of blood transfusions. I haven't heard of any. And then the other thing is, of course, contaminated needles. I haven't said that yet. So sharing contaminated needles, you'll see that as well as a way of transmitting it. All right, it is a retrovirus, and this just shows you what happens with a retrovirus. Its genetic information is actually in the form of RNA instead of DNA, and so it contains reverse transcriptase to convert RNA into double-stranded DNA, so everything works backwards. And so you can read the process and just know that it is a retrovirus, and that it works differently. It works in reverse. Everything's different than it's supposed to be. The problem with it is that it does bind to your CD4 cells. I'm sorry, not cells, it's proteins. CD4 proteins on the cell membrane, of your T helper cells. All right, so it binds to the CD4 on those proteins, and that's on your T helper cells. So it prevents them from working. Basically, it's going to destroy that cell. It's going to destroy those T helper cells. It will kill that cell that gets infected. And then what's going to happen is when that cell is destroyed, it breaks apart and it releases pieces of the virus and spreads to other cells. And this is a video I'll post for you on retroviruses you can look at. This is a slide that shows you the virus and how you get infected. I'm not sure if this is in your textbook or not, or if I borrowed this from some other place. Do let me know and I will provide this for you. this just tells you basically what I just mentioned, the structure of it. It binds to the CD4s and the T helper cells. One of the things I need to mention is that we do look at the ratio of CD4 to CD8. CD4 and the T helper cells, we measure this, and so 8 to 1,000 is what we typically look for. And so we measure this, and when it starts to drop to a certain level, which we'll go over in just a minute, less than 200, you develop full-blown AIDS at that point. So you're infected with a virus. All right, that means you have the virus. It is replicating in your body. We're not taking medicine trying to suppress that. But until it does sufficient damage and those CD4 rate numbers drop, you don't develop full-blown AIDS. And so our job really basically is to keep those from dropping so you don't develop full-blown AIDS. That's what we want to do. All right, so clinical manifestations. You can get infected, and it has its windows, and it can be quite a long window before it shows up in your bloodstream. It depends on what kind of infection you have in terms of how you were infected. It can make a difference, and I've listed that down the bottom. So you can be serologically negative. You can be positive but asymptomatic, meaning you've got the virus in there. We recognize the virus is in there, but you're asymptomatic. And then as it progresses, you go into the early stages of HIV and then full-blown AIDS. When you develop, there's some specific diseases you look for full-blown AIDS. The problem is that window period. There is a window period that it varies from person to person based on how you were infected, where you don't know that you have HIV. So you could actually be transmitting the virus because it hasn't shown up in your blood yet and not know it. So that's that window period where it doesn't show up. I've already mentioned when we look at the T helper cells, once the virus gets in there, it starts destroying your T helper cells. And your body's replacing things. It's trying to keep up with it, but eventually what's going to happen is it's going to destroy so many of them that your T helper cells, your count, when we look at your CD4 count, is going to be less than 200, and you're going to be in full-blown AIDS if we haven't been able to stop them. What do we look for in the diagnosis of AIDS? AIDS, there are certain disease processes that we see. Usually they're strange sounds really awful to say, that's not, but they're unusual, or I guess atypical or unusual infections. One of them can be something called pneumocystis carinii, pneumocystis carinii, which is a specific type of pneumonia that you tend to see with people that have full-blown AIDS. Kaposi sarcoma. Kaposi sarcoma would be another example. We typically see the diagnosis of Kaposi sarcoma is associated with an AIDS diagnosis. So some things that you don't normally see. They may have like an overwhelming yeast infection. That would be an opportunistic organism. Presence of antibodies. This just shows you 4 to 7 weeks after blood transmission. So it can be picked up 4 to 7 weeks after you've been infected. But after sexual intercourse, it may be 6 to 14 months before you see antibodies. So you may, actually be transmitting the virus. And then the Western blot is actually the test that we can do. More about that later. All right, this shows you the primary and latent period. I've already mentioned that. Primary infection phase is when you get the infection and you seroconvert. That can be anywhere from 1 to 6 months, depending on that window that I talked about. The latent period is when all viruses can, if they want to. Some of them don't want to. They can actually lay low, and I won't say dormant, but they actually be in the background replicating, and you don't have any symptoms of it at the point. So latent period, the virus is replicating. It is destroying those T helper cells. The T helper cell gradually starts to fall. This can last 10 to 11 years if untreated. It can actually be very short, too. Like I said, one gentleman I went to hospital with, knew him quite well. Within a year, he was gone. It was very, very rapid. And then once, and this is without treatment, like I said, Magic Johnson, 20 years later, still doing great. Overt AIDS, T helper cell count is less than 200, or they have one of those unusual illnesses I was talking about. What is the treatment? You can just look over this. We do have some really great medications that are doing a great job, but they are hugely expensive, and they're very difficult, one, to tolerate, and the regimen is very complicated. And so we have a real problem with getting people to take their medication correctly. And I know you're thinking, well, hey, they should take it correctly. But it's really hard. If it makes you violently ill, you're less likely to take it. It makes it really hard. So we do have some issues with taking the medication and being adherent to those for just some reasons. And they are very expensive, so not everybody can afford those. There is really some controversy about in other countries that are poverty-ridden countries. They can't afford it. They don't get the medications, and they don't give it to the individuals in their country. it's really there's an ethical dilemma there. New drugs, you can read through that. They're working on vaccine development. I keep hearing rumors that they get close, but then I never see anything come out, so I don't know. How do we assess the immune system? I've already mentioned that one of the systemic symptoms that you see, let me pause there, I sort of blew into that one. Okay, that ends AIDS. Any questions? Any questions about AIDS? Or HIV? Okay, now this is just a slide to say, okay, overall, how do we assess the immune system? One thing is we look at what's called a complete blood count with a differential, and basically the differential is we draw blood out of a vein, and we look at all the cells that are in there. And the differential means we look for the different types of lymphocytes that we talked about, and we talked about those back with inflammation. We can look at immunoglobulins. I've already mentioned we can measure and see what your immunity is to certain things, and we can also measure and look at the complement system to see if the complement system is functioning like it should. And then there is actually a skin test we can do where we actually inject you with something up underneath the skin and see if it reacts that way or not reacts. All right. In terms of treatments for immunodeficiencies, these are just some ways to do it. We're not going to get into that now, so that will not be on your test. You don't have to worry about that. All right, questions about immunodeficiencies? 150, okay. I know you're probably wishing hard to the end. Let's see if I can get another one, or if I lock it up again. Open. Okay, that takes us to, here. Let's do, in your textbook, the next one's hypersensitivity, isn't it? All right, I got it right today. I have done it wrong before. Okay. Next in your chapter is hypersensitivities, which in my opinion is a little bit easier topic. All right. Did you know? Look here. This is a henna tattoo. They had a reaction to the henna tattoo. You actually see what happens there. Isn't that, well, I say it's amazing, but you don't want that to happen, but it is, so now you know it's done now. I hate when it happens. I don't know why the first three slides always go on their own. I don't know why that is. Here are your learning objectives. You can read over that. But this is an example of poison ivy, poison oak, very similar to that. We're going to talk about seasonal allergies. And then, of course, drug reactions. You can actually have reactions to medications and cause hypersensitivity reactions. So these are all examples of hypersensitivity reactions. Okay, so what is a hypersensitivity? A hypersensitivity means that you're having an exaggerated response to some sort of allergen. An exaggerated response to some sort of allergen. A lot of times it's an environmental allergen. And because you're having an excessive response, we're going to talk about when you have hypersensitivity, you're having release of histamine from the mast cells. And as we talked, mast cells, the histamine causes all sorts of changes in the body and it actually causes damage to the tissues. So when you have this exaggerated over-response, you can actually cause the body to be damaged by that. So it is not the allergen itself that's causing the damage, it's the body's response that's causing the damage. And then a lot of times you'll hear an allergy used interchangeably. We're talking about an allergy or an allergen or hypersensitivity. An allergy is basically going to see the effects that you're going to see in response to this hypersensitivity reaction. All right, the types that we're going to look at, we're going to look at type 1, and that is an IgE-mediated response. Type 2, which is tissue-specific, and we're going to have examples. Type 3 is immune complex-mediated, and again, I'll go over that a little bit more. And then type 4 is cell-mediated. So those are the ones that we're going to cover. All right, so when you look at a hypersensitivity reaction, first you have to know that you can have varying degrees of that hypersensitivity reaction, particularly type 1. Type 1 is where you're going to see this most often. You can have immediate response when they come in exposure to it. You can have anaphylaxis, which is an overwhelming, life-threatening response. Anaphylaxis is an overwhelming, life-threatening response. And this is, again, different degrees of response. So I can respond, I get exposed to something, and I can immediately respond and have reaction to it. And it can just be the allergy things that we normally see, runny nose, watery eyes, all those sort of things, and rash, any of those. Anaphylaxis is an overwhelming response. You have massive degranulation of those mast cells and histamine is released. And so you're going to have problems with all that histamine being out there. And we'll go over that a little bit more. And then you can also have a delayed response, which is a little bit scary. They cannot respond for several days, maybe a week. So they can actually have a delayed response. Okay, so now let's look at type 1. Type 1 is what we do, it's usually referred to as our allergies. I have allergies, so that's a type 1 response. It is, it again can be an immediate, localized, or systemic reaction. It can be anaphylaxis. Anaphylaxis, again, life-threatening, we'll talk about in a minute. The local reactions that we'll see, rhinitis means runny nose. You can have food allergies. Bronchial asthma is now, it's recognized, it is a hypersensitivity inflammatory reaction. Hives, breakout hives, little bumps, big bumps, I'll show you a picture. And an atopic dermatitis, I'll show you a picture of that. Alright, so type 1 hypersensitivity is IgE mediated. Alright, IgE, that's an antibody that's sitting on the mast cell. So when IgE comes in contact with whatever it is you're allergic to, it is going to stimulate the mast cell to degranulate. And out comes the histamine and the leukotrienes and all those other things that we talked about. Now remember, histamines first, leukotrienes have to be synthesized, they come a little bit later, which is going to be really important in just a second. So what's going to happen is the IgE is going to say, okay, I'm going to release this histamine, and it's going to cause degranulation. One thing I wanted to mention, when you have histamine release, you have two receptors, which I mentioned before. Histamine 1, those are associated with all the allergy symptoms that you see. Histamine 2 are in your stomach and are related to hydrochloric acid secretion. What are antihistamines? They work against histamine and block histamine's ability to get on these receptors and cause you problems. But I will tell you, if you're going to take an antihistamine, you have to do it before the histamine is released. So if you think you're going to have an allergic reaction, you need to go ahead and take it, because once the histamine starts working, it's going to be ahead of the antihistamine, and it's going to cause some problems. So you need to take it ahead of time. We always tell our patients to take it before the symptoms start. What can we see? What kind of symptoms can we see? Itching all over, and maybe breaking out a little bit of rash, scratching all the time, urticaria. Conjunctivitis, that's red eye, those red bloodshot eyes. Rhinitis is the runny nose. Okay, and you can mark a line right there, because those are the ones that you typically see. So mark those. Those are typically the ones you see with an allergic reaction. These are caused by histamine. When you think about the runny nose, what does histamine do? What does histamine cause in the body? It causes vasodilation and increased. What does it call? Increased when the cells move apart? Permeability. Increased permeability. And so what you're going to have here, and it explains your runny nose, is when you have that vasodilation, which causes more stuff to pool in that area, that's going to cause those tissues to swell, so your nose is going to get stuffy from that. But you're also going to have increased permeability, which is going to allow that clear fluid to run out, and that's where you get your runny nose from the increased permeability. But you're also going to have swollen tissues there, and that's going to cause the stuffy nose. It's not, in some cases, it's not that you have, any mucus in there, it's that the nasal passages are so swollen that you can't get air to move through there. All right, so we drew a line because those are the ones you typically see. Now, with anaphylaxis, it is more serious. You'll see these here. You can see these, but we're not going to worry about these with anaphylaxis, because these are the things that can actually cause death. Because anaphylaxis is a systemic response, you have an overwhelming systemic release of histamine, not just where you're getting exposed, but all over your body. You're going to cause, because of the vasodilation, you can have profound hypotension because of that vasodilation. Meaning the blood vessels are getting wider, which, of course, blood pressure is determined by how tight are your blood vessels. So now they're wide and relaxed, and it's going to drop your blood pressure. In the lungs, it's actually going to cause bronchospasm, which means it's going to cause the lungs to tighten and squeeze to the point, it can be to the point where you can't get air to move. It also causes, which is not on here, you can add this, something called laryngeal edema. Laryngeal in the larynx, in the mouth, we're going to have oral laryngeal edema. Why can I not say edema today? All the tissues, because of the histamine, are going to swell. All right, so the throat can close up. The mouth, and you'll see, I think I got a picture, I'm going to post that on the side for you, a picture of somebody, their lips are just huge because of the mucous membrane has swollen. It can also cause dysrhythmia in the heart. This is a lot of catechol and emphysema releases and stress in the body. All right, so that's what you typically see here with anaphylaxis. The GI cramping and malabsorption, it's going to be seen more with food allergies. It's actually a response of where you're taking something into the gastric tract and you're allergic to it there. And so you're gonna see a lot of GI cramping and malabsorption because of that.
What was the larynx?
Laryngeal edema, that's when your, the larynx, actually all the mucous membranes here are gonna swell. So it's gonna be very difficult to move air in and out. You've got a bronchospasm going on, you've also got all this closing up because it's swollen, it's narrowing because of all the edema, and you can't, actually they can quit breathing. If you don't get this under control, they can't breathe, they can't move the air. So anaphylaxis can be life-threatening. You'll learn next semester we have a medication that these individuals who have a risk for or have had anaphylaxis in the past have to take with them at all times. So if something happens, they go ahead and inject themselves, and it will address these symptoms, and she'll tell you more about that next semester. All right, so that's the signs you may see. How do we, some people are actually predisposed to them. My husband has terrible allergies. He passed it along to my daughter, one of my daughters. But there are ways that we can test for it. We can do food challenges if you think it's a food allergy. They can also do some skin testing for foods as well. Skin testing is where they'll do a control. They'll inject you with just a little bit of histamine up under the skin. It can be on the back and be on the arm. And that histamine, I'll tell you, I've had it done, itches like the devil, which is what it's supposed to do. But oh my God, that was the worst part of the whole thing was the histamine side. And then what they'll do is they have this whole list of it's a little bitty needle, and they'll just scrape it with each one of those different types of allergens, and they'll watch to see where you react. If you swell up a little bit and start itching in that side, get red, they'll document that and determine what you're allergic to. So that would be skin test. We can also do some laboratory testing, again, looking at specific antibodies. And then we have something called desensitization, which is the treatment that we use for people who have allergies like this. If you're predisposed to allergies, we've done testing and identified what your allergies are. We can actually give you allergy shots, which means that we expose you to a small amount of whatever you're allergic to. And when we inject you that small amount, the immune system recognizes it, and it will actually start to build up an immunity to it over a period of time. You have to be very careful to it because you never know when that one injection is going to cause anaphylaxis to occur. So usually it's done in a doctor's office. You have to wait 30 minutes after in the doctor's office before you can leave, that sort of thing. So desensitization is actually allergy shots. We have to do it very carefully. Questions about that? Okay, well, we've mentioned primary and secondary exposure. When we look at allergies, the first exposure is when we identify something. It's called sensitization, when we recognize something and react to it. The second time, on re-exposure, we're going to have a bigger response to it. The more mast cells are going to degranulate, and we explained that when we talked about why the immune system it reacts like it does. The first exposure, we haven't ever seen it before. We've got to develop a recognition to it. There'll be some response, but not a lot. And then the second time, we're going to see a bigger immune response. This is a picture of atopic dermatitis. You can be allergic to detergent, anything. This looks like they've rubbed up against something on their stomach. I'm not sure what they might have come in contact with.
That nickel from the belt buckle.
Oh, the nickel from the belt buckle. There you go. And this is an example of individuals, they have an injury, and they actually have a back brace. And so wherever that back brace is touching, they were allergic to the material, and it's caused them to react there. This one is terrible. This is an example of hives. I can't imagine how miserable this person must be. And then bronchial asthma, I told you that it is considered to be an allergic reaction now. It's called a reactive airway disease. It's been moved into its own category because of the way it responds. And basically what you have during bronchial asthma is the individual is exposed to something that triggers this, or whatever the allergen is that they're allergic to, and it causes the release of histamine. We're going to see several things that occur in the lungs. We're going to see all this tighten up because of the edema that's going to come. Now, in asthma, it doesn't have to be. It can be just today's a bad day and you have a little bit more than usual. I'm not talking about anaphylaxis here. They're going to have some edema that develops, so it's going to be a little bit swollen, so tight. They hear some wheezing when you listen to them. They're also going to have increased permeability, which means they're going to have more mucus production. And so those are the symptoms that we see with asthma, bronchial asthma, and it's all related to an allergic reaction. And we treat them differently. We treat them differently than we do, say, for example, somebody that has chronic obstructive pulmonary disease. That's a different mechanism of disease. And this shows you the mast cells and how they degranulate, and then the things that we see in response to that. So this is a good little slide for you to look at in terms of studying. Anaphylaxis I've already mentioned, so I won't go over that again. You can read through this slide. This just shows you all the things that are involved in I will mention one thing. In anaphylaxis, and as related to type 1 hypersensitivity, I've mentioned thoroughly what histamine does in there. But the one thing I mentioned this on arterial vasodilate to the body, what is that going to cause? When everything dilates, the vessels dilate, the arterioles dilate, what does that cause? No, when the blood pressure is tightening, what is relaxing? What will happen to your blood pressure? go down, because it's not gonna move. The bigger the hose is, the less movement you're gonna have, okay? So when it dilates, we're gonna have hypotension develop. All these things are involved in it. The one thing I did want to mention was leukotrienes, which are really important in this process because they act just like histamine, but they come later in the process. So we have histamine that comes first, and we have all these dangerous symptoms that develop, but it will wear off. But then unfortunately we have leukotrienes that are being synthesized by the mast cells, and they act just like histamine, so they keep those symptoms going. So that's the problem with anaphylaxis, is the leukotrienes come in later and keep the process going. What will happen when the bronchioles constrict? What will happen? You think you can breathe well? No, you're going to have difficulty breathing. It's going to be tighter. Depending on the amount of it, it can completely occlude the ability of you to take a breath in. Okay, questions about type 1? Okay, type 2. Let me look and see what time it is. All right, 10 more minutes. You're lucky, 10 more minutes. You see the light coming at the end of the tunnel at this point. I've got to stop eventually. That's what y'all think eventually she's got to stop. All right, so let's look at type 2. Type 2, you want to know what the mechanism is. So you want to test, you want to know that it is tissue specific. So it is going to respond to a specific tissue or cell. It can cause damage or destroy a cell by 5 mechanisms, and those are listed on the screen. We talked about the complement system. We talked about phagocytosis. It can also, again, get the tissues destroyed by complement neutrophil granules. It can be antibody-dependent cell-mediated cytotoxicity, but the end part of it is that it actually causes damage to a target cell in your body, whatever that cell may be. One of the best examples is something called Graves' disease, which is when you're actually having antibodies attack the thyroid tissue and destroying the thyroid. So it's tissue-specific. Examples of type 2 hypersensitivity. Transfusion reactions are a good example, and I've got a slide here somewhere that I'll have to find to tell you a little bit more about that. Transfusion reactions are when you're getting, when we give you blood, unless there's some sort of emergency where we can't do it really well, and sometimes that will happen, hopefully very rarely, we will type what we call it, we do a cross-match, type and cross-match, I can't even say it, type and cross-match, where we identify what type of blood you have, and then we're going to match it, and then we're going to start looking at the specific type. We're also going to look at the receptors that you have on the cells and try to match somebody else's blood to you as specifically as we can, because if we don't, what's going to happen is your body's going to recognize this is foreign blood and it's going to attack it. So you're actually having a hypersensitive reaction that's occurring straight into the blood and damaging and killing off those cells, which is life-threatening. Rh disease, you'll see that is can cause anemia of the newborn. And then you can also have drug reactions that can cause it too, a Hoff famicide. Let me give you this when we talk about, and it's not in your textbook, it's actually in a different section of your textbook, and it's really hard to find. So I'm just going to give you this information. When you look at blood types, type A, your type A blood, you have an antigen, an A antigen. You have an A antigen. But you have antibodies to B. Antibodies to B. So if I mistakenly give you B blood, what do you think is going to happen? You've got antibodies, so those antibodies are going to attack. You're going to have a transfusion reaction. All right? If you have type B, that means you have a B antigen, but you have antibodies to A. Antibodies to A. If you have type AB blood, then you have antigens to both A and B, so you have both antigens. AB blood, you have both A and B antigens. That's for AB blood, you have A and B antigens. And this is considered to be the universal recipient because you can take A or B blood. Because you don't have those antibodies. You have antigens to both. Okay, and if you're O, you don't have antigens to either one, but you have antibodies to both. Okay, so you don't have any antigens, which means you can donate to anybody. Anybody can take that blood. But guess what? They can't receive any other blood. okay, because they have antibodies to both A and B. So they can't take other blood, but they can, they're the universal donor. All right, so if something happens and you have a transfusion reaction, it's going to cause those cells to clump, it's going to cause those cells to lysis, and they're going to have massive breakdown of cells, and it causes the kidneys to fail, and lots of bad things are going to happen. Okay, so that's a transfusion reaction. In terms of the Rh disease, there is something in the Rh system, there is, on those cells, there's something, it's expressed in the red blood cells of these individuals, it's the D antigen. Okay, so it's expressed on the red blood cell, and it's a D antigen. D and antigen, D as in dog, antigen. If you have it, you are considered Rh positive. If you have it, you're considered Rh positive. So if you have the D antigen, you're Rh positive. If you don't, you're Rh negative. So in Rh disease, what you have in that situation is an Rh negative mother and an Rh positive baby. And so what's going to happen is, because the baby has it and the mother doesn't, and this is on second exposure, it's not the first exposure, it's not her first baby, but on the second time, if she has a baby that's positive, and she's already been exposed, there's a little mixing of the fetal blood, so the first time she got a little exposure to it, and she developed those antibodies. So the second time around, if this happens and there's exposure to it, we have what's called hemolytic disease of the newborn, and that's where the mother's blood is actually attacking the baby's blood and destroying it because it recognizes it as foreign. Okay? The good news is that we have medications to stop this from happening. We identify these individuals very early on, and we prevent this from occurring. Okay, so questions about Rh disease. And then drug reactions, that can occur usually on second exposure. Sometimes you'll have them occur on the first exposure, but usually the second exposure, again, antibodies to that will cause a reaction to occur. All right, and here is, I forgot I even put that in there. Right there's everything I just told you about the ABO system and the Rh factor. Completely forgot to do that. That's new, I added that in, forgot all about it. Okay. All right, 4 minutes, top 3. Can we do it? Top 3. Top 3 is immune complex mediated reaction. So what will happen is, I've got a video I hope to show you. I'll get it on the website for you, but what is an immune complex is an antigen-antibody complex. When the antigen and antibody come together so that the antibody can try to destroy it. In some cases, these cause these complexes, they always cause the complex, and they cause them in 3 sizes. There's a small, medium, and large. Small are not a problem. The body gets rid of those and no problem at all. The large one, same thing. Phagocytases, they're recognized by the phagocytes and they're destroyed. It's the mediums we have problems with. They sort of circulate around, and nobody gets rid of them, and so they have to find a place to get rid of it to go. And so what they do is these antigen-antibody complexes actually deposit into the tissues or the vessels, and any time you have something foreign that's not supposed to be there, it causes an immune response. It causes that inflammatory reaction that we talked about. So what happens is you have these antigen-antibody complexes, the medium ones is the problem, and they can't get out of the body. They can't be destroyed or be gotten out of the body, and so they're floating around, and so what they're going to do is they're going to deposit into the vessel walls of tissues, and that's going to cause an inflammatory response. And then some examples here that are listed in your textbook that you can go over. So that basically is the top 3. You had those immune responses, and I think I have on this page. Yep, here we go. The immune complexes, the large ones, the macrophages get. The small ones are just excreted from the body through the kidneys, no problem. But it is those medium-sized ones that cannot be gotten rid of. And so they have to go somewhere, so they'll deposit into the tissues and the vessels, and that's going to cause an inflammatory response. All right, and this is, I'll post this for you. We've got 2 minutes, and we'll show this video, and I will leave you alone if I get to come up. Don't leave yet. I'm going to get this video up. Maybe.
Ask your question after lecture.
Uh-oh, got something for you. Don't leave.
Immune complexes consist of antigens and antibodies bound together. Although large immune complexes are engulfed by phagocytes and removed, intermediate-sized immune complexes are not readily removed. These intermediate complexes react with and activate complement. For example, complement activation in blood vessels causes basophils to degranulate, which causes vasodilation. Immune complexes entrapped in blood vessels or other tissues, such as kidney glomeruli, activate complement, which attracts neutrophils and causes them to degranulate. Neutrophils release enzymes responsible for tissue damage.
Okay, so I think I've got that posted for you. And so that leaves me with type 4 hypersensitivity reactions and also with the autoimmunes. I do not have those finished, so what I will do, and I apologize, I try to get things finished, but we really need another day for all this, and I can't come back on Friday. So I will post you a video that will have that information in it so that you can watch that video and finish that little part of your chapter. It's not a very long video. I actually have one already that I'll post for you. And